Laxminarayan, on behalf of Princeton Club of India, a very warm welcome to you. Thank you for joining us. And it's a great privilege to have you with here. We have a lot of people very interested in this session, which is going to be the second session of the Princeton Club of India. I think obviously we've all been in India. You've become in many ways a household name because of the often the citations that you've had so often in the media and on TV, and we're all very excited and eager to hear from you what you've have in terms of for us to look forward to. A lot of questions obviously on our mind, how did we get here, which is what we've called today's talk, and the corollary, where do we get to where we want to be, and what is a reasonable place. Also, I think your work has succeeded in making epidemiology, which was in many ways an obscure field, something that's extremely relevant to all of us. All of us know now what it is, but maybe if you could just explain a little bit about how your models work, and what are the kind of inputs that feed into a model, and what's the best way to use them to inform policy, and that's, I guess, going to be something of key interest for us. So without taking any more time, a very warm welcome to you once again on behalf of the Princeton Club of India. Thank you for spending this evening with us. And may I request you to kindly start in your remarks to us. Thank you very much, sir.
Sure. Just give me a second. I'm just going to try to figure out a way to project this in 1 second.
Just a couple of, I guess, basic housekeeping rules. So we've got some questions in advance, and we will be sharing with them. I think we'll have time for a few people to get on and ask their questions, but for everyone else, Samantha Chai, who was one of your students, Dr. Laxminarayan, will be moderating the entire Q&A session. So I think she's going to do a great job of it, and we're all very eager.
Sure. Well, happy to be here, and this is a pleasure to speak with, I guess, all Princeton alums, I guess, in this crowd.
Well, a lot of Princeton alums. We have a lot of other people. We have about 136 people who registered, and we are on the YouTube stream as well. We have, I guess, a very large number of Princeton alums and a couple of Princeton current students.
Excuse me.
We have some people from the other alumni groups and other institutions as well.
Okay. So actually, I think you may have to give me access to present. I think it just needs to be.
Okay. All right. Let me just make you a host, and that should. Okay.
Good. Okay. All right. So let me see. Get this on. Oh, share screen. So you can see the slides now?
Yes.
Okay, great. So yeah, I'll just kick straight off it to COVID in India, and I think most of you know what's going on with the disease. So I'm actually going to some of these slides will be familiar with to Samantha, because these are slides that I showed my class, and in fact my class is on disease dynamics, economics, and policy, disease ecology, economics, and policy. And the whole thesis of this class is that infectious diseases are spread by viruses and bacteria, but an important mediator of how diseases spread is really human behavior. And I think that's all true, all too much the case for COVID as well, where our trajectory here has been because of how we behaved and government policies and so forth. So infectious diseases have always spread around the world. So these are PFCRT mutations to malaria, and so so these are basically mutations which confer resistance to chloroquine, and they've spread around the world. Now, remember, these usually take about 20 years to spread from one part of the world to the other. They might have started in Southeast Asia, and then it takes about 20 years to get to Africa. But some diseases spread a little faster. So, oops, sorry. So this particular strep pneumonia 23F, which is a very common strain of pneumococcal pneumonia, which still kills about 200,000 children in India every year, and is basically, it didn't take very long for that to spread around the world. It's the most predominant clone of strep pneumonia around the world. And NDM1, which many of you might be familiar with, New Delhi metallo-beta-lactamase. This is named after New Delhi because it was located in a patient from New Delhi. Important drug-resistant bacteria found in a patient in Karolinska in Sweden, and then spread around the world to more than 150 countries in just a space of 2 years. So, it can either happen in 20 years or, just in a couple of years. COVID, of course, is the much faster moving example. Now, the fact that these diseases emerge in animals is not surprising at all. So a lot of people are wondering, well, did it start in a lab in Wuhan, et cetera, et cetera. It's not that surprising that it just started in wild animals, because most coronaviruses actually do start in wild animals. And these are graphs showing the number of emerging infectious disease events. So starting from about 20 in 1940s, to a high point in the 1980s. Of course, this paper was written in 2008, so it didn't cover the entire decade quite. But the fact is that every day of the week, there is some virus that would like to make a jump. Every week of the year, there's some virus that does make the jump. But not every virus manages to jump from one human to the other. They often hit evolutionary dead ends. You often find, it happens in Princeton as well. You'll have a student who dies of meningitis. Now, that student got infected with a strain that was extremely virulent. It killed that student off. It happens on US campuses, it happens in India as well, but was not good enough to make the jump to another human being. So now that particular form doesn't come from animals, but many of these are zoonotic, which means they do come from animals. And you can see that it's been increasing over time, partly because of publication bias. We study these a lot more, but also because we are actually infringing on wildlife a lot more these days than we ever did. And we also have the ability for human-to-human transmission. So before, some hunter in the jungle would have encountered Ebola in a dead gorilla. That's actually how Ebola was, might have transferred to humans. They might have eaten the dead gorilla that had died of Ebola, and then that person would die as well. Today, that person is not eating that dead gorilla in a forest and then dying themselves. That person is doing it in the middle of a crowded city, which means that that virus then has an opportunity to find its way from one human host to the other very, very quickly. So this is probably what happened with COVID as well. And clusters of these are reported every day. I mean, so for instance, COVID as well was reported on an email that people who work in infectious disease. So I get an email every morning. Some of you probably get stock market updates. I get an update on every unusual infectious disease event around the world. It's called ProMed. And the community that works on this is what we get. Every day we get something. Now, most of the time it's nothing, but then you track it to see if something shows up repeatedly a few days later, and then that's what really starts causing problems. So please see if I can minimize this. Okay, here we go. Now, risk of zoonotic disease happens to be concentrated in South and Southeast Asia. No surprise there. And that's because this is where there's a lot of animals and a lot of humans, and animals and humans living in close proximity to each other. You have to remember that of the total mammalian biomass on the planet, 60% of that biomass is animals that humans eat. 30% is humans themselves. And then only 10% is all the other mammalian biomass, whatever it might be, giraffes and zebras and hippos, and everything else is just 10% of the biomass. So when you're putting a lot of animals that we eat close to a lot of people, we are creating ideal conditions for these animals to pass on their viruses to us. And from a perspective of being able to transmit viruses, pigs are not very different from human beings. I know a lot of people think that men are pigs, but turns out that all humans are like pigs. And it's very easy for viruses to reassort, and flu viruses are constantly circulating between pigs and humans. And one thing which we probably don't realize is that the average pig in the US, for instance, has traveled a lot more than the average American. I'll wait for that to sink in. And you wonder, why does the average pig travel so much? Because the average pig is traveling to Mexico, to Canada for a weaning operation. They travel internationally. Lots of pigs travel to China, because China is where a lot of pigs are consumed. So the average pig is a much bigger international traveler without passports than the average human being. So this is something which we have to realize. There's an entire huge volume of animal trade and movement of animal protein that's happening. And on top of that, you overlay this wild animal stuff that the Chinese have going on. And this is what a wet market in China looks like. It's literally live animals, dead animals, wild animals, domesticated animals, blood, gore. It stinks. This is what the whole place looks like. And it's unfamiliar. I think in India, you probably have this in northeast of India, I'm told, but it's not a general occurrence. But in Southeast Asia, it's all too common. In Indonesia, in parts of Malaysia, certainly in Laos, Cambodia as well. And effectively, this is this is what we've been warning about for a long time, that this close proximity between animals and humans is not a good thing from the perspective of disease transmission. And these viruses typically start in wild animals. They then might find an intermediate vector, they spill over into domestic animals, and then there's a spillover which comes into humans. And there's an amplification going on at both stages. And this is our epidemic curve that you're looking at. But this is already too late. We should have caught this when it was out here, over here, over here. Instead, we catch it when it's somewhere over here, and then we say, how do we stop this virus? Truth be told, we really can't. It's very difficult to, because we don't know enough about it by the time it gets here. And if we had a smart system, we'd have readiness at this point. We'd have early detection earlier. We'd control the virus before it got here, rapid response. And that's how we get to limit the peak. And this is the benefit of not having the peak going all the way out there. And this is the number of deaths and cases that we can avert if we were to do this smartly. Now, I'll give you the example of SARS in China, because as much as we think of coronavirus as being such a terrible situation, a more terrible situation actually came up in 2002, which was with SARS, which had a case fatality rate of 10%. Now, with coronavirus, it's probably going to be 1% or less than that. SARS killed 10 times as much per case. And it spread pretty quickly, not as fast as COVID, but still pretty fast. And if you see the history of SARS, it's remarkable because it's so similar to how COVID happened. November 2019 was when COVID was discovered in a person in Wuhan who probably got it at the market, which is where they sell seafood. Now, in 2002 November, there was a first report of a cluster of atypical pneumonia cases from Guangdong CDC to China CDC in Beijing. Now, China CDC, China was very different 20 years ago. So the amount of openness, we don't think of them as being very open right now, but they're far more open now than they were back then. And back then, there was no obligation for a country to report a disease outbreak into the world as well. And February, they had determined that SARS was caused by a coronavirus. They had a public announcement that we have something called SARS, but they didn't say it was a coronavirus. There was a transmission event, which I'll talk about in a second. And then it took till April for WHO to determine that SARS was caused by a coronavirus. Now play that entire story in your head to see if that had happened in this particular case, how much more of a problem we would be in, where it takes something like 6 months to figure out it's a coronavirus. By April, we have vaccines underway, right? But SARS could have killed millions of people. We were just lucky that it died out on its own, but it wasn't because of us being smart. It was a very few, viruses or bacteria have actually been eliminated, have basically been eradicated. But this one was eradicated of its own volition. It didn't happen because of anything that we did. And in February of 2003, there was a doctor who checked in from Guangdong into the 10th floor of this hotel, the Metropole Hotel in Hong Kong. And he basically ended up giving SARS to people from Canada, Ireland, US, Singapore, Vietnam, and Hong Kong. In fact, I knew, the person who treated the patient from Vietnam. That doctor subsequently died. And SARS eventually killed about 10,000 people, 50,000 cases, 10,000 deaths. All happened really quickly and spread like a flash around the world. Fortunately, it just didn't sustain because it's a very special property for a virus to sustain in a human population. It often doesn't, it doesn't have all of the features to be able to do that. Now, this novel coronavirus seems to be able to do it quite well, which is why it's scary. But SARS clearly was not able to keep up its act for too much longer. But the fact is that the spread literally on one floor of one hotel in one city, Hong Kong, and went around the world just from that, which just shows, these were people who got it from the air vents, in that Metropole hotel. And so this is not a new topic for people who've been working on it for a long time. This is an article that I wrote in 2017. And if you read the whole thing, this is actually available for free. It's the Milken Institute review. And if you go to the Milken Institute review homepage, I believe they've put this on the homepage to remind people that they published this a while ago. But this basically is a slightly longish article. But basically, the main point here is that a pandemic would not have to take millions or even hundreds of thousands of lives to shut down international commerce, which is what we see today. Under 300,000 deaths, but it's pretty much shut down the world. It didn't kill tens of millions, it didn't kill hundreds of millions, but it shut down the world. So even a few thousand deaths over a short period would be enough to inflict significant damage on the global economy. And it's just the world we live in now that we can't ignore these, any more going forward. We look at 1918, but we almost will never see 1918 happen again. Why? Because information travels a lot faster today than it did back in 1918. So we're always going to be able to prevent pandemics from killing a lot of people, but we are not going to be able to prevent pandemics from disrupting our lives in a major way. And I don't have to prove that to you. You're all sitting in your homes, and you're experiencing this right now. And if you look at India, for instance, India did some things right in the very early stages. As soon as China had identified coronavirus as a causative agent on 7th January, remember, they did it on 7th January, not in April like they did for SARS. And there are reasons for it, which is long. They were almost forced into it by the way the international health regulations have changed. But in a series of steps, the government of India has basically been quite proactive at screening on the borders, making sure that people were quarantined very early, making sure that flights were shut down, that the borders were shut with Nepal and so forth, prohibiting the export of N95 masks and PPEs, and evacuating citizens and making sure that the first cases were all fully locked down and quarantined. That made a huge difference. And I gave a bunch of interviews in mid-March basically saying that you're not going to be able to control it right now, but we need the lockdown in order to buy the time. And we need to create an enormous and an affordable and easily available testing infrastructure and build up the mechanisms to be able to take this virus on the chin, because there really is no other way. And the foreign minister of Singapore put this best in any interview that I've seen on this, which is he basically said that coronavirus is going to be a test of three things of countries. It's a test of your health system. It's a test of your ability to govern. It's also a test of how much social capital there is that people will actually comply and do smart things to protect themselves, which is, for instance, not pile on to liquor stores the minute that they open. Now, we all know that India lacks all three of these. We lack certainly the health system. The ability to govern, India runs only on two modes, either full steam ahead or nothing at all. And true governance is the ability to go on second gear, to calibrate, to be able to enforce social distancing, to be able to enforce mask wearing. And that ties in with the third part, which is that, we are not very cut out to be supportive of each other as citizens either. And if you think of the whole migrant crisis, yes, we blame the government for it, but it's also partly, employers. It's also partly people like ourselves. We don't have a mechanism by which we're able to come forward and prevent a social tragedy when something like this happens. But at that point, I basically said there'd be about 300 million cases and 1 or 2 million deaths. And I still stand by that, in the sense that we've just pushed this entire epidemic out. It's not going away anytime, because the death toll might be lower because we might have overestimated the mortality rate perhaps, but the number of cases is certainly going to be that high, simply because that's the number of infections that come from COVID, just from how fast it actually moves. So India's proactive approach has been that, if you see, now these are not adjusted for population. And India shut down when there were just about 300 or 400 cases. It had probably, I would say, 5 deaths, much, much lower than Iran, Italy, or Spain. So if you're wondering why India has not seen a big takeoff, it's because if Italy had shut down here, it would not have seen that spike in cases. It's because they tried to shut down here that the momentum of the virus keeps, taking them forward. And similarly for India, we shut down here, the momentum still keeps taking us forward. Today we're not here. This is already a bit outdated. So we've crossed the 10,000 mark. We're at the 50,000 case mark, or whatever it is. But and we're about to even cross Italy perhaps. But fact is that we did some very, very good things very smartly, very early on. And I just want to take you back into epidemiology, because I just put those couple of slides in when to explain how this entire field comes about. And the field actually goes back to one interesting example, but certainly others as well, which is really this idea of where disease itself comes from. And disease was believed to be because of smell. Bad smell causes a disease, was what was believed. Malaria was, the name really means bad air. And Florence Nightingale really said, look, we've improved hygiene amongst the poor, you've basically gotten rid of disease. And cholera, which is the big killer back then. You would burn camphor or garlic or chloride. And if any of you read A Life in the Time of Cholera, which is a good reading now during quarantine, you'll remember a famous line from there, which is that every day on the hour there would be a cannon fired from the garrison, because of the belief then that gunpowder purified the air. And they truly did believe that stuff. But cholera essentially was this way. It would routinely emerge from the Bay of Bengal, spread across India, across Central Asia, into Europe, and into the US. And before there was any global agreement on anything about war prisoners, or about torture, or any of that stuff, the first international agreements in the 1850s were about countries notifying other countries about disease outbreaks that they had. And particularly of those, the ones that they wanted to know about were cholera, plague, and yellow fever, and at that time, smallpox. Now, this is a famous story called, which was sort of the origin of modern day epidemiology. And there was basically a big outbreak of cholera in London. And some of these places still exist. So you can actually go to Broad Street, as a matter of fact. And there's a pub right here in front of where the spot is. And this is Piccadilly, and this is central London. And John Snow, who was then also physician to the royal family, he basically plotted all these dots of where the cholera cases were. And he noticed that the cholera cases were not clustered around these pumps, this pump, or any of these. They just happened to be clustered around the Broad Street pump. And so what he did was he went in and he removed the handle on the Broad Street pump. That's what he did. So he basically thought that maybe sewage had contaminated that particular pump, and he removed the handle, and that's what ended up reducing the deaths. So sorry, I skipped a slide here. So it was already started coming down like all epidemics did, but when they removed the pump handle, it started coming down much faster. And there have been other sort of epidemiological studies. This is of plague in Bombay in 1905. And you wonder why epidemiologists say there is a sort of peak and this is coming down. This is very consistent with the math of how epidemics work. And I'll get to that in just a second. And I'll explain to you why it works in that particular way. And so in our particular model, what we look at is, again, we look at who assorts with whom. So do kids hang out with kids, or do adults hang out with adults? And we have a lot of data from India on how this actually happens. As it turns out, kids do hang out far more with kids. They have more numbers of contacts and more durations of contacts. And what we also find is that testing is important. So India actually has one of the lowest test positivity rates in the world, but the number of tests is also extremely low. In fact, most countries have higher test positivity rates than India. So if you really were to say increasing the number of tests does not change the positivity rate, that's really not true. countries that test more actually find more cases. We plug in the number of international air travelers into our model. Again, a question might be, why is Delhi, why are Delhi, Maharashtra, especially Mumbai, Punjab, Gujarat, Tamil Nadu, all these the epicenters right now? It just happens to be that we're separated in time. When we don't have one epidemic in India, we have multiple epidemics. It's almost like a state-wise epidemic and perhaps even a sub-state epidemic. Same reason why New York has so many cases, but Texas doesn't. Just that the epidemic is seeded in different places in different points in time. And the seeding is essentially a function of how many people came in, because this disease was not native to India. It came in from outside the country, and it probably came in from tourists from Europe. And once it's seeded, it came through the airport. So most of the initial cases are going to be there. But rest assured that the remainder of India will also get it in due course, because they have no immunity to this virus either. So I'll skip through some of the details, but this is something that you have probably seen, this idea of a reproduction number, which is the average number of people that an infected person will infect. This is a major variable for us, and trying to estimate this is really what much of epidemiology at this time is around. So I'm going to jump actually quickly to say that we have good ideas about incubation time, time to hospitalization, days in hospital and so forth. And so this is a very slow moving virus in the sense that it spreads very quietly through the population. Really, you don't see it very much. And suddenly it'll seem like it was never there before, and it jumps suddenly to start having a climbing case rate and a death rate. We're not quite at that point yet, but that's been the behavior of this virus in other places. In the US, it took 50 days to get from 100 deaths to 50,000 deaths. From 100 deaths to 50,000 deaths just took 50 days. That's the remarkable sort of sweep of this virus as to how it suddenly takes over almost like an earthquake. Now, again, another question which comes up is, are temperature and humidity going to be important? Maybe a little bit. I mean, I wouldn't say nothing at all, but these figures from China show that not really clear how much that really benefits. The reproductive numbers on the y-axis and the humidity is on the x-axis. So even if you have 100% relative humidity, you're still left with a fairly large reproductive number of about 1.5. So certainly not as bad as 2.5, but it doesn't benefit you a huge amount either. So it may slow the virus down, but it wasn't going to stop it. Most of what we knew earlier was from this Diamond Princess cruise ship, because it was a very good example. There were 3,700 passengers and crew members on that vessel, about 10 initial cases on Feb 3rd. Feb 4th onwards, every passenger was quarantined to their rooms. Nobody was allowed to leave their rooms, right? Even so, on Feb 20th, about 16 days later, there were 619 cases confirmed, which just shows how quickly this virus has spread, because it doesn't sort of take its own time. It really, it jumps from person to person rather easily. And isolation quarantine may have prevented about 2,300 cases, but finally about 634 people tested positive amongst all of the tests. And in our model, we assume actually more than half. We assume about half are asymptomatic. We assume about another 30% are mild infections. And of the remainder, we assume about 80% are moderate. So you're talking about, at the end of the day, you're talking about only about 3% are severe and 1% actually die. And all of these are fitted now to data from India as well, not just Italy, Spain, and the US. Now, the evidence on children is kind of interesting, because the other countries have not worried so much about kids, but in India, we've worried about kids because kids in India are more malnourished, are more stunted, have less immunity than kids in other countries. So children are less likely to be infected and less likely to be hospitalized in other countries. And these are data from China. And the illness is also less likely to be severe. But when you really look at it, children have lower severe disease, but they have the most amongst anyone until 65 plus age group. So basically, it's not like there's no risk at all. And India has about 130 million children, so something to be slightly concerned about. So we did these models in the initial stage. This is where it comes, but I'm not going to get into the model per se. I'm actually going to explain this in a much simpler form. And I'm going to explain this in a way that all of you know how to use Excel, and you can use your Excel spreadsheet when you leave, or maybe you can do it on your computer since you're on your computer. And you can see how fast diseases can grow when they are growing at an exponential rate. So at a doubling time of 3 days, and remember, in the initial stages when we had our warnings about 300 million infections, the disease was doubling at 2 days in Italy and about 2.5 to 3 days in Spain. And at a doubling time of 3 days, 100 infections can grow to 500 million, actually to 420 million to be exact, in just 66 days. That's all it takes. So 100 becomes 200, then 400, then 800, then 1600, and 3200, and so on and so forth. So it only takes 12 doublings to get from 100 infections to 420 million infections. If you increase that doubling time to 5 days, you've bought yourself a lot more time. So you've got 110 days. It's just these two lines that would be sufficient to advocate a lockdown. Because with a lockdown, you basically have bought yourself another 44 days just by increasing the doubling time by 2 days. And 44 days is a lifetime in terms of public health preparedness. So this was the logic behind the lockdown. And it was just this. It was that we can buy some time. And without this, we would have seen a peak just about starting to grow now. And slowing down the doubling time for a longer period through intermediate measures has a greater impact than sharp lockdowns. And I'll explain that in just a second. So I'm just going to go through and say that this is we modeled the first 21-day lockdown. And there would have been about 15 times the number of cases at the end. Remember, the lockdown begins and lockdown ends, but the benefit of the lockdown goes far beyond the lockdown, right? Because you've changed the trajectory of the epidemic. The epidemic, instead of growing like this, is growing like this. So obviously, we don't get to observe this growth. We only observe this growth and say, oh my God, the epidemic is still growing. Did we achieve anything with the lockdown? Fact is that if we had not done the lockdown, we would have been growing over here. Bombay would have just been swamped by now in terms of cases. And this is total infections and so forth. So the national lockdown was effective in buying time, reducing cases in the following weeks. And what will happen when the lockdown is lifted? There were different options. It depends on whether we follow general social distancing. We can have multiple lockdowns in the future. All of these were options. Now, as I mentioned before, the case detection rates and test rates, actually, this is more recent data. These are sort of positively correlated with each other. So if we look at all test rates logged and case detection rates are our estimates of the number of cases. And this is not test positivity. This is basically how many cases you would expect on the basis of deaths and how many cases you actually observe. So cases based on deaths would be that every death today was approximately about 100 cases about 2 or 3 weeks ago. And so we know the number of cases that were actually reported 2 or 3 weeks ago. And so we estimate to see, well, how many cases were actually reported? And that ratio gives us our case detection ratio. And what we find is that countries that don't test a lot, like India, Pakistan, Bangladesh, Indonesia, Brazil, don't have a very high case detection ratio. So in other words, we are missing a lot of the cases. It's likely that for every case that is being reported through the public system, there's probably another 15 other cases that are not being reported because they were mild, asymptomatic, and so forth. So this is what that curve really looks like. So this is what we would have had in the absence of the lockdown. This is what we got with the lockdown, with a hard lockdown. And this is what happens if you have the lockdown followed by social distancing. So this is a pretty major difference from having that lockdown. You've knocked down the peak and you've bought almost about, by this model, almost about 2 months of time, until about June or early July. And all of these were the reasons for the lockdown. Obviously, a huge economic cost, which I certainly won't deny. And I won't deny that it could have been done much more, much better. Now, at this stage, we are still in very uncertain mode. Our models, which are fitted to data from Maharashtra, I mean, I'm just showing you those, are still pretty unclear because the blue line is the actual trajectory of cases, and the red line is the projection going forward. Now, you can see that the fit is just as good whether you're reaching 200,000, 2 million, or 5 million infections. So at this stage, it's too early to tell because we've not climbed this epidemic curve enough. So we'll have to wait and see how things progress in the next couple of weeks before we can tell what our peak is going to look like and when it's actually going to be hit. Our best estimate is going to be June or July. We run hundreds of these models every day. But right now, the honest answer is it's really too early to tell. What is very clear is that the lockdown has really scaled back the growth rate in India. That's indisputable. I think you see that in the papers every day. But what is also indisputable is that once the lockdown lifts, that doubling time will shrink and we will start climbing a lot faster. And, in some sense, there's no getting away from it. This is like a meteor hit on the earth. You can't, we really can't escape this. There is no such thing as people, going for another year and a half without getting the infection unless we get to herd immunity or something like that. So where do we go next? What we do post-lockdown is important. We have to ban mass gatherings. We have to encourage distancing where possible. We have to encourage face and nose covering, hand washing, teleworking where possible, everything that we can to slow down the infection, but without shutting down the economy. So we've got to make some sensible choices. In fact, I was just on a call just before this one, on what might on post-lockdown scenarios with government, for instance. And the question was about Mumbai suburban trains. And I said, look, anything which is important for people's livelihoods and economic activity, you would allow that. So in some sense, you would prioritize the Mumbai suburban trains over opening schools and colleges because one has a far greater immediate impact on the economy than the other. I certainly agree that kids need to go to school, but I think if kids didn't go to school for another 3 months, it's not going to be the end of the world in a sense. Whereas if folks can't go to work for 3 months, that's going to really be a problem. Similarly, we should allow for public transport and buses, but weddings of 1,000 people are just not necessary. It's not like the economy thrives on mass weddings. And these are, or on religious or social or cultural rallies. We can probably postpone those for 3 months without any great damage. So I think we need to prioritize activities that have economic value, even if they spread the virus, and deprioritize the ones which are not going to be particularly useful with respect to the economy. And I think we need to put the economy first very clearly as we go forward. Now, every day of lockdown, this is not my estimate, but this is NCER and other estimates, about $4.5 billion. I think it's even more than this. But we don't need this any longer because we've already bought enough time. But COVID, whether we like it or not, is going to be with us for some time. And in the longer term, I would say, depending on how things pan out, herd protection is a possible end goal. I know there's a lot of back and forth about whether there's immune protection and so forth. And the fact of the matter is that if you did not have antibodies developing to the virus, you would not be able to clear the infection in the first place. The fact that people self-clear the infection itself means that we're able to develop immunity. Whether that immunity lasts for 1 month or 3 years or for a lifetime is up in the air. But we've almost never seen viruses that you only get 1 month of immunity. Even for SARS and MERS, that post-exposure immunity is something like, I don't know, it's about 1 year for SARS and about 2 years for MERS, or maybe I have it the other way around. But we at least will buy about 1 year or 2 years of immunity, by which time a vaccine will hopefully come in. But this may be an end goal that we don't have to work towards like the Swedes are doing, but we may reach there just because we are, as a country, not really able to have that level of control over population movement like the Chinese do or the South Koreans do. And we may just get there because that's just how the country operates. So we don't have to do anything. But if the virus does spread rapidly, we'll get there even by September, October, and it may come at a huge cost in the shorter term. But it's possible to get there and hopefully try to reverse quarantine the elderly and so forth to make sure that it doesn't have that kind of a cost. But there's a lot of this virus which is just not within our control. And I think that's the first lesson to learn, which is this is not a virus that operates on our time scales or what we would want it to do. We have one very blunt instrument against it, which we've already used now for about 45 days. And we can't keep using that blunt instrument again and again because it kills as much as it delivers. And we're going to have to find some fine instruments, and those are limited in our society. Thank you.
Thank you so much, Professor. So you've given us a lot in the past few minutes, and I've been seeing some questions pop up in the chat. Just a note for participants, instead of messaging me or some of the hosts directly, why don't you send your questions to everyone just so we have fewer repeats in the questions. And so now we're going to switch over to the Q&A period, if that's okay with you, Professor. So since I'm organizing the Q&A and I get to pick which questions are asked, I'm going to start with my own, if that's okay. I was reading one of the articles you posted on April 26th, about 2 weeks ago, and you were also mentioning this at the end right here. You said that the lockdown has achieved its purpose. Extending it may not be worth the cost. And I'm wondering which specific thresholds had been crossed. And secondly, could be a point in the future where we cross that threshold again, which will necessitate another lockdown?
So I think I heard all of it. I missed a couple of words, but you were asking about what threshold had been crossed to lift the lockdown. I think the threshold that had been crossed was basically that the 3-week lockdown effectively bent the curve. The 5-week bent it even further. So we have essentially bought ourselves enough time all the way through to June or July. The feature of these models, that is almost a first principle, you don't have to run the model, but it's basically simply this. If we return to the doubling time that we had prior to the lockdown, which is a 4-day doubling time, we essentially return to the same peak that we would have had with or without the lockdown, right? So the peak is going to be the same if we return to that behavior. But because India is a large country, there's a lot of people to be, still to be infected. So it's to some extent, we've bought the time, and what we do with that time is really up to us. Beyond this now, there's no more every day additional lockdown just buys you one more day. It doesn't, and it's not clear that it's worth, pushing the epidemic out by one extra day for a cost of $4.5 billion. Now, going forward, do you think that, is additional lockdowns perhaps necessary? It may be, but it may also be too late. So if you have an epidemic curve that's climbing and we get to, a really sharp part of the curve, there are other aspects of lockdowns which are bad during a climbing epidemic curve. For instance, in India, most people seek care from the private sector. Do we really want to prevent access to healthcare from the private sector precisely at the time when people really need to access it? Will you cut off their access to public transport at a time like that? And what kind of distress and discord might that actually cause? So I think these are important questions because lockdowns come with huge costs of their own, and it's not necessary that we use that instrument all the time.
Yeah, I completely agree with you. I think that's the point that you make. Next, we have a question from Ranjan Paul, who is the former president of the Princeton Club of India. So he said, you had a TV conversation with Barka Dutt a month ago, in which you had estimated that by mid-May, we would be at 70 million infections and 500 hospitalizations, even with a severe lockdown based on a complex model that you had developed. In retrospect, those numbers seem exaggerated compared to current estimates. Where did your numbers go wrong? What is missing? Or did the severity of the India lockdown exceed your model's assumptions?
Yeah, good question. So I don't remember this because I at the time that I did the interview with Barka, we didn't have post-lockdown, scenarios. We might have had, some sort of a guess based on what had happened in China. Now, obviously, we thought that India was not going to be anywhere close to it. And I have to tell you the truth. I frankly was surprised that India chose to lock down. It was an extremely bold decision at that time, and it was not something I even expected. I thought it had to be done, but I was not sure that the government actually, had the gumption to do it. So we had assumed that there would still be significant transmission, and a lockdown might be a very mild sort of a one. And we didn't really think that it was going to be a complete shutdown of the entire country. In fact, I wrote something the day before the lockdown saying that we really ought to have state-level lockdowns. Now, keep in mind that even today, we've probably had a lot more spread than we know. We probably had a lot more deaths than we know because deaths are also being undercounted. There's probably far more infections than we realize. Now, this will only be apparent in hindsight because our testing levels are so abysmally low that we cannot pick up cases through testing. We're going to only pick it up in retrospect through what are called serosurveys. Basically, serosurveys are studies to see if people have antibodies to the virus. And my guess is that today, probably across the country, about 1.5% of Indians have already experienced that infection or been exposed to it. Now, this is what you see in other countries as well, that it spreads very silently in a across the country. The difference that makes this virus more challenging is that even if it had a fatality rate of only 0.1 or 0.2%, like the flu, it's still dangerous because even the 1918 flu pandemic, only 25% of the population was estimated to have been exposed. Here, that's because they already had some prior exposure to similar strains of the flu virus. Here, we don't have any known immunity to this virus at all, nothing whatsoever. So unless we find out something, we would assume that we go all the way to the 65% number. And 65% of India is a very large number of people. So even if you were to do a 0.2% mortality on 65% of India, that's a very large number. So I think we're playing with large numbers here. And back then, we were looking at what a lockdown might actually achieve in India. We certainly didn't expect to go to 11-day doubling time. That is pretty impressive. But at the same time, let me also say that the story is not over yet, simply because we don't have all of the data in properly. We still have serious undercounting in some cases. There seems to be some politics between the ruling party and the opposition parties in terms of how deaths are counted. So these will come to light well into the future when we actually have census data and we actually know, what people died of. So it's still a little early to tell this.
Thank you. Yeah, I think that's also a great answer, and it'll be interesting to see what the numbers show post-emptively. So next we have a question from Rebecca Needham, who is a Princeton alumna and a current Schwarzman Scholar.
Hi, Professor. Thank you for your talk. My question is whether you could speak more about the response to the pandemic in Kerala, and if you could talk about whether Kerala's response should be emulated by other states, and to what degree can other states attempt to emulate Kerala's response. Thank you so much.
Sure. I think you know the answer to that. Kerala is a special state. So Kerala's health indicators are same as New York, better than New York City, in fact. And Bihar is like Sierra Leone. There's just no comparison. So, and as the health secretary of Kerala said a few weeks ago, he said you can't build a health system for tackling an emergency in the middle of that emergency. So Kerala has been preparing this for decades. There is no way other states can emulate what Kerala did or does. There's just no possibility. They're completely different countries, right? So I think it would be great if they could, but it's just not going to happen. I think Kerala and I think Vietnam, there was a recent newspaper article which compares them. They've invested in healthcare. And the thing also about lockdown preparedness is that preparedness during the lockdown is that we have to be clear about what you can prepare for and what you can't. You can buy beds, you can buy ventilators, you can buy PPEs all within a month. You can't buy a trained pulmonologist. You can't buy an epidemiologist. You can't buy good critical care doctors. Those are 3-decade investments. If we invested in that doctor in 1960s or 1970s, they're available to you today. And if we haven't made those investments that far back, and I'm sure most of you know that most medical colleges and most doctors are in Maharashtra and south of Maharashtra. And north of Maharashtra is a much smaller proportion of doctors. So you can't just come up with the personnel who are needed. So these are things that we should have thought about 30 years ago, and it's too late now.
Great. Thank you for your answer, Professor. Next, we have a question from Rakesh Prasad and Manuj Garg, who asked a similar question in their registration. They said, do you see a future where pandemics will occur more frequently? And is there evidence that world leaders and citizens have learned enough from this current pandemic to prevent future ones?
I don't know, you tell me. I mean, the next pandemic could happen next year. It could happen 100 years from now. We really don't know. I would say that shutting down, wildlife markets in China might be a way to reduce our chances of the next pandemic. But that said, these are, every day it's, these viruses are trying to jump, and it's going to be hard to figure out exactly when the next such event happens. But we have to know that it is going to happen. It will 100% happen. We just don't know when. So again, I don't know if there are theories about it happening more frequently. but that may also be an artifact of the data. And the one kind of pandemic which is more likely to happen in the near future is really related to antibiotic resistance. But that's because we are consuming a lot of meat, and that's antibiotics are being fed to animals that live in very close proximity to us. So we might see a bacterial pandemic. And remember, the plague is a bacterial pandemic. Obviously the 1918 flu was a viral pandemic. So it can be of either kind, bacteria or viruses, or it can be fungal infections, which we're now seeing now. So it can be any of these, and the causes could be quite different, but all of them tend to point to something that we did to disturb the natural system or to raise animals close to us, and that's what the consequences are.
Great. Next, we have a question from Susan Vernon, who is a Yale alumna and a teacher at the American Embassy School.
Hi. So I'm kind of wondering about if this is India's opportunity for a Singapore moment in terms of improving some behaviors that are definitely unhygienic and tend to spread disease, things like spitting. Even now with this, since we know the virus can survive on surfaces like plastic, throwing down trash that then someone else has to handle. So I'm wondering if there's an opportunity here for the country to make some changes in overall behavior.
I so hope that what you're saying could come true. I think all of us it would be fantastic if that would happen. And I was very happy so in some of the earlier stuff I wrote, I would always include spitting. And it was important to mention that because people were talking about sneezing and all of that, but spitting was so obvious out there. And I see that, it's part of the government's sort of communication messaging as well on the spitting. They're really focusing on the spitting. In fact, Delhi has banned the sale of gutka, tobacco, basically because of the spitting issue. So I hope that this will at least be one part that sustains. Even if some of it sustains, that would be really helpful. So let's hope that what you're hoping for comes true.
Thank you.
Great. So I'm seeing there are a lot of questions in the chat, so I'm just going to refer to a few of those. The first question that we have is from Michael Chow, who says that mutations seem to occur rapidly with COVID-19, with numerous strains confirmed at this point. I have heard that it is rare for virus mutations to result in more lethal strains of the virus, but that it is possible. How worried are you and your peers about this?
The true answer is we don't know. So 1918 flu did mutate to being a more virulent strain, and virulent means it kills more people. And the argument that is made there is because during the first wave, the virus was basically spreading in the trenches in Europe during the First World War, where it was very easy for the virus to jump from one soldier to the other. They all died in the trenches, killed a lot of people. So it didn't cost the virus anything to be virulent. Typically, it costs the virus something to be virulent, which is the minute when it kills a person, then everyone else sort of steps back, and it makes it difficult for the virus to jump if it kills people. So killing is actually a bad strategy for a virus, except in situations like in World War I, where it didn't really hurt the virus at all, and might have even helped the virus, because any virus that made it into the trench actually survived because it managed to kill a lot of people. So that was a feature of the virus that increased its fitness. In the case of coronavirus, if I had to bet, I would bet that it would probably move in the opposite direction of being not too virulent, because it probably is not going to help the virus if every time there's a death, there's going to be a shutdown of that area, and it's going to be difficult for the virus to transmit if it were in that area. So I think some of our control measures will push in the direction of lower virulence, but these are just conjectures. We have no idea.
Great. So next we have a question from Arvind Malhan, who says that the percentage that test positive in India is quite low at 4 to 5%, and those with acute health conditions and morbidity also seem low. What is your hypothesis on causes of these observations? Also, since testing level is low and quality of data is suspect, only government sources, how can data-based inferences be made?
That's a really good question. I think the data are very suspect because anytime the government tries to control data, then it becomes suspicious. For instance, we only get the number of tests conducted. We don't actually get any information on whether there are duplicate tests done. So we happen to know, for instance, that patients have to get 2 negative tests in order to be declared COVID-free. All that has gone into the mix of your denominator of your number of tests, right? So if you are counting all of those as tests and then saying I'm finding 1 positive for all of these tests, that's not a valid indicator at all. I want to know of all the people you tested, how many were positive. The government doesn't provide that information. They only tell you the number of tests that were conducted. And we know that there are multiple tests conducted on individuals. So I think there's good work. There's also too much, misinformation out there also in terms of how some of these rates are calculated. So I think I don't trust the data. I mean, unless we're able to get the original data to see, well, how many patients were tested, I wouldn't be able to conclude that this percentage test positive, which is part of the narrative, it's not, I mean, it's almost certainly not true at all.
Great. And I'm seeing 2 specific questions about India's lockdown, one of which is from Neha Goel, who says, do we have any insight on how the virus has spread inside India's lockdown? Who's getting it and why? So I'm assuming she means delivery people and other essential workers versus people that are staying inside their houses during the lockdown. And another question has asked your opinion about the green, yellow, and red zones that have been established in major cities.
Right, on the first one, see, it's a highly transmissible virus. It's very hard. And when people are living in slums and all in close proximity to each other, and there are doctors working, it's very hard to stop a virus. You can only slow it down, but you can't actually stop it. And particularly in a country as crowded as India. And also because I have another slide somewhere, I can show it to you. But basically, if you have on the x-axis, the testing rate per capita, and on the y-axis, the proportion of the state that is in a red zone, it's almost a straight line. It's almost a straight line, which means that states that test more have more districts in the red zone. So if you're going to determine your red zone based on cases you found, which in turn is determined by how much you tested, the best way to not have any red zone districts is to not test very much at all. So I just think that testing is inadequate to be able to determine which a red or a green zone is.
So just to follow up on that, do you think that there is a point in demarcating green, yellow, and red zones, or not necessarily, since it might just be an indicator of testing?
Well, I think there's a value in cluster containment at a very local neighborhood level, or perhaps on a street level, to be able to contain at that level if you thought there was a cluster of cases there. Let's say a whole family is infected. There it's worthwhile. To shut an entire district down because it had 20 cases just doesn't make any sense. Okay, great.
And we are running out of time, so I'm going to ask one final question. I see in here from Manoj Garg, a report in Economic Times today says the utilization rate of COVID beds in India is at 1.5%. Assuming that this is correct, what do you make of it?
So first of all, this COVID bed number, the denominator is a bit, it's just, they're just beds. These are not ICU beds necessarily. I did see that number. The point of this is also that the point of the lockdown, which is there is an efficient level of lockdown. The efficient level of lockdown, would have been something that ended after 21 days or maximum 30 days, after which point you actually turn and face the virus, in which case you actually have the beds actually fill up, right? So if you apply a full control measure and then you're saying, I don't see the beds filling up, that's like someone asking me, why didn't you see 300 million cases by July? It's because you impose the control measure. It's like, going to the doctor and saying, the doctor says, if you continue to smoke, you're going to die young. And then you stop smoking. And then you ask the doctor, why didn't I die young? The answer is because you stop smoking. So here, it may be low, but that's because we are living in a highly unnatural situation of the biggest lockdown of so many people ever in human history. This is not a natural situation. So I think that as the lockdown lifts, which is the natural place, we go back to real life. And then, it's unfortunate that the bed capacity is going to fill up, but that's what the beds are there for. The beds are there to take care of patients. I think, this daily tracking of cases and worrying about the increasing caseload and saying that we stay in lockdown forever is a terrible idea, because then we would have killed people's livelihoods. We would have killed people, through hunger, and we still will have to face the virus at some point afterwards. So we're just postponing a problem.
Great. Yeah, especially in India. And I'm conscious of our time, so I know that our time is up. So I just wanted to say that I can't thank you enough for spending the past hour with us and improving our knowledge about this topic that's highly talked about. And for the audience, I'm not sure if all of you know this, but Professor Laxminarayan was my senior thesis advisor at Princeton. So it was a great favor for him to agree to speak with us all today. Professor, I know this has been an extremely busy time for you, but your work is really important and is clearly benefiting a lot of people. And whether we've been staying up to date by following the CDC guidelines or just educating ourselves on WhatsApp University, there has been a lot of new information that you've brought to the table for us. I want to thank all of you participants as well for really engaging with the chat and asking questions. And I apologize for not getting through all of them. And finally, I want to also thank Shiv and Anam for helping put together this event, from getting the information into newsletters and spreading the word, to also coordinating logistics and setting up the Zoom call with me. And I also want to wish Anam a happy birthday from to your house in Mumbai under lockdown. And finally, I hope that everyone is staying healthy and safe. And I wish you all the best wherever in the world you are. Thank you, guys.
Thank you, Sam. Thank you.
Thank you very much on behalf of the PCI, Dr. Laxminarayan. This was really a wonderful session. For everyone who registered, thank you for coming. We hope to have another program very soon. We will keep all of you informed. This has been truly wonderful. The recording is there on YouTube if anyone wants to refer back to it. Thank you very much, everyone.
All right, take care. Bye-bye.